That'll work.
All right. Good morning, everyone.
Good morning, good afternoon.
Good afternoon now. It's still a minute. All right. So, my name is Dr. Elkouzi. I'm one of the junior fellows at the University of Florida Center for Movement Disorders Neurorestoration, now called the FIXEL Center for Neurologic Diseases. I am going to talk to you about sleep and Parkinson's disease. I know this is a hot topic for many. A lot of you have many questions about this. I'll try to make it easy, explain the physiology of sleep, why do we need it, what are the areas of the brain that are responsible for this, what happens when those areas get disrupted or sick, and what are the consequences, what are the types of sleep problems that a patient with Parkinson's disease will experience, and how can we tackle those issues, all right? Feel free to stop me and ask questions. I'll be happy to answer those. Okay. So I'm going to start with definition of sleep. Sleep is a periodic state of rest in which your eyes are closed usually, but sometimes you would see somebody who's asleep with eyes open. That happens. And the consciousness is partially lost, so that there is a decrease in bodily movement and responsiveness to external stimuli. That's obviously different from coma, for example, where if you stimulate somebody, they would not wake up. If they're asleep, if you stimulate them, they should wake up. Sleep is important. It's important for many things. First, it's important because it lets the cells communicate with each other in a different way than they usually do in an awake state. And that part is very important. That part is thought to be responsible of removing certain toxins in your brain that build up when you're awake, all right? And sleep affects every single organ and system in your body, ranging from your heart, your brain, your kidneys, your lungs, and even your mood. Chronic lack of sleep obviously causes many problems. It causes high blood pressure, it causes diabetes, depression, obesity, and other problems too. This is a slide that shows what areas of the brain are responsible and what areas are involved, okay? You would see in blue the areas that promote sleep, and in red the areas that promote wakefulness. If I can grab your attention to look down and to the right to the suprachiasmatic nucleus, I would say this is the regulator or the pacemaker or the center that would switch or control the sleep and wakefulness, or what we call in scientific term the circadian rhythm. If you hear that from your doctor or from, if you're reading something on the internet, you'd often see a circadian rhythm. They're talking actually about sleep-wake cycle. So this suprachiasmatic nucleus is strongly connected to the eyes, and that's why when it's bright outside, we're awake physiologically, because it gets the light and it gets integrated in the suprachiasmatic nucleus, and wakefulness switches on. When it's dark, this switches off, and that's when the nucleus above it, the VLPO, actually turns on and promotes sleep. There are various other areas that are involved, including, for example, a gland in the middle of the brain called the pineal gland. This gland secretes melatonin, a hormone that is, that promotes sleep, and that's what you take, when you have a problem sleeping. You go over the counter and buy melatonin. That's what this gland secretes. And that's how it's thought that when you take melatonin, it promotes the sleep. We will talk about this in details. Other areas that you can see are responsible for wakefulness. They secrete neurotransmitters that gets you activated and all awake and alert and ready to go. So what are the stages of sleep? There are different There are different stages of sleep. They are broadly divided into a REM sleep behavior and a non-REM sleep behavior. REM stands for rapid eye movement. I will show a video later on where you would see somebody who's sleeping and having those rapid eye movements so that you can imagine what I am talking about if you did not already see it. So the non-rapid eye movement stages of sleep are stage 1, 2, 3, and there is a rapid eye movement that happens every 90 minutes, and that's when you actually have your dreams. So stage 1 is simple, it's the transition to sleep. Stage 2 is the light sleep before you get into the stage 3. This is when you start having physiological changes of sleep, including slowing of your heartbeat and breathing, and that's when your muscles start relaxing. Stage 3 is what you really need, because that's the stage where you relax completely. Your breathing, your heart rate, everything goes down, you're completely relaxed, and if you don't get enough of that stage, you will not feel refreshed the next morning. You will not feel that you had enough sleep. REM sleep, on the opposite, this is the one we talked about where you have your dreams. This is completely opposite because physiologically, your heart rate goes up, your breathing goes up, you're very active, and your brain paralyzes your body so that you don't move while you're dreaming. I think Dr. Lang talked about this earlier in the morning, where he said people with Parkinson's disease often have a problem with that because this paralysis does not happen completely. So they are either not paralyzed at all or they're only partially paralyzed, and you see them acting out their dreams, which is a big problem with Parkinson's disease and sometimes happens many years prior to the diagnosis, 20, 30 years sometimes prior to the diagnosis. There are various factors that affect sleep. Neurotransmitters is one. You can talk about GABA, which is a relaxing neurotransmitter in the brain. Norepinephrine, this is the opposite, and it's actually make you awake. And this balance between neurotransmitters is very important because if you get too much of one, for example, you drink too much coffee, you get too much norepinephrine, you're awake. And that's the purpose of coffee. If you're on medications that promote GABA, like the benzodiazepines that we sometimes prescribe for patients with Parkinson's disease to improve their sleep, you get too much GABA, and that relaxes you and puts you to sleep. Other neurotransmitters are involved too. I'm not going to go over those. There are certain genes that control the excitability of neurons, and those are called clock genes. This is an evolving field. I'm not going to talk too much about it, but you should know that the genetics influence this to some extent, okay? And we're learning about this as we move on with the field of sleep and Parkinson's disease. So what are dreams? Why do we dream? We don't know exactly why we dream, but we know they happen. And on average, you spend about 2 hours per night dreaming. And that happens during the REM sleep behavior. Remember we talked about the stages of sleep where they have a REM and a non-REM. This happens during the REM sleep behavior. Some people dream in colors, some people dream in black and white, some people know that they dreamt but they couldn't remember their dreams, other people remember every single detail of it, and we don't know why exactly this happens. So it's thought, the hypothesis is that this is a way of your emotions to get out psychologically, but of course there's no way to prove that. How much sleep should I get? So the American Academy of Sleep Medicine recommends for people aged 18 to 60 years of age to have about 7 hours of sleep per day. But the National Sleep Foundation says that up to 8 hours is okay. All right. If you're sleeping about 10, 12 hours per day, there's something wrong. If you're sleeping only 3 or 4 hours per day, that's also wrong. Okay, so we have to find the balance of staying around the 7 to 8 hours per 24 hours per day. And that's the recommendation of the American Academy of Sleep Medicine. So what's insufficient sleep? Insufficient sleep is when you're not getting enough sleep. You're not getting this dedicated time, about a third of your day in bed. This is a prevalent problem in the United States, and about 30% of adults have this problem for various reasons, not because of Parkinson's disease, but for other reasons too. There is a diagnostic criteria for that. So, for example, if your sleep time is 3-4 hours, if your sleep is interrupted, if you sleep for 1 hour, wake up for half an hour, and then sleep for another hour, sleep for 2 hours, and then wake up, all this can contribute to insufficient sleep, and you would experience all those symptoms, where you get irritable, you have problems concentrating, you're easily distractible, and you're fatigued all the time. You're restless, you have problem with your energy, you feel that you can't move your arms, you can't move your legs. That's very common when you don't get enough sleep. Now, you have to be careful because some of those symptoms also happen in patients with Parkinson's disease for other reasons, whether they are under-medicated or have problems with their medication, or if they have advanced Parkinson's disease, their disease is progressing, they can have those problems. If they are depressed, they can have those problems. So that's why visiting the doctor and discussing this is very important, okay? And this is there's a very close relationship between sleep and anxiety. If you're lacking sleep, you're gonna have anxiety. And the more you're anxious, you're going to lack sleep. So to break this cycle, you have to tackle both. You have to improve sleep, and you have to treat anxiety. Treat anxiety whether by behavioral therapy, whether by medication, that's okay. But as long as you're moving in both ways, you're doing the right thing. So how to monitor? You could have a sleep questionnaire that your doctor gives you, and I'll show examples of that. That's a subjective questionnaire that you fill, and it has many questions regarding when you go to bed, how long you stay in bed, and I'll show an example. And objectively, this can be monitored by something called actigraphy. I'll show you an accelerometer that can be placed on the wrist, where you can wear and sleep, and will monitor how much sleep you're getting and the pattern that you're sleeping. Your sleep doctor usually uses that to monitor if you're getting an insufficient sleep, if you're getting problems during sleep, where the problem is exactly, because that's very important for a sleep doctor, or even for your neurologist to know. Is it a problem for you falling asleep? Is it a problem for you waking up frequently? This is an example of a questionnaire from University of Cambridge that show what they ask about exactly. For example, if you go to question 8, you have difficulty falling asleep at night. Very straightforward questions that anybody can answer. A lot of times you will see a patient filling everything as yes, which is sometimes can happen. It would be better if you exactly can pinpoint where the problem is. Is it a problem of waking up frequently? Is it a problem of waking up early in the morning? Is it a problem of difficulty falling asleep? Because the doctor can manage accordingly. So, how is this relevant to me as a patient with Parkinson's disease? Why is it important? So, with age, we know that the circadian rhythm, the sleep-wake cycle that we talked about earlier, changes. And people tend to sleep earlier and wake up earlier. And they have, less non-REM stage 3 sleep. This is the type of sleep that is required for you to feel refreshed and more energetic in the morning. So with age, and simply with age, not with Parkinson's disease, this tends to get less. So in addition to that, you have Parkinson's disease, and now you have other problems with your sleep. So not only you're not getting enough stage 3 sleep, you're having problems falling asleep, or you're having something called rapid eye movement sleep behavior disorder that we're going to talk about. Or you're waking up frequently because you have to use the restroom, or you're deficient in dopamine and you need your medication in the middle of the night and you wake up. So in addition to that, you have another problem in patients with Parkinson's disease. And it is important to remember that your symptoms get worse when you lack sleep. So you wake up different in the next morning. If you tell me that you're a Parkinson's disease patient and you're traveling a lot, that does not tell me something good, because that tells me that you're lacking sleep and your symptoms are worse because of everything else going on. So it is important to remember that you have to dedicate the required time for sleep each night, especially in patients with Parkinson's disease. So what are the common problems? The common problems, number one is insomnia, and that's the inability to fall asleep, or inability to go back to sleep when you wake up in the middle of the night. Another problem that is common in patients with Parkinson's disease is the vivid dreaming or nightmare, and that can be simply as a symptom of Parkinson's disease or as a symptom of the medication. We'll talk about different types of medication that can cause that. And the rapid eye movement, sleep behavior, periodic leg movement, and sleep apnea, which can happen in Parkinson's disease in addition to patients without Parkinson's disease. How do you manage this? You manage this either through interventions or behavioral techniques. So with interventions, you can use medications or you can use devices. For example, patients with obstructive sleep apnea, they tend to use a device called a CPAP or a BiPAP. Some of you are familiar with that because they have an additional diagnosis of obstructive sleep apnea. We'll talk about this later also. And some patients require medications. Example of a well-known medication to some of you here is called clonazepam. This is a class of medication that falls under benzodiazepines, improve GABA, which is the neurotransmitter we talked about earlier that relaxes your brain. And this can help promote sleep and quality of sleep too. Behavioral therapy. Sleep hygiene is very important. Raise your hand if you know what sleep hygiene is. All right, okay. And then behavioral therapy. We'll talk about different kind of behavioral therapy that you can have. So, in sleep hygiene is a technique that everybody with Parkinson's disease should use. Okay, that promotes the time and quality of sleep that you can have. That improve your symptoms and improve your quality of life overall. So you have to stick to a sleep schedule when you have Parkinson's disease, because if you don't, your sleep becomes erratic. You lack stage 3, you're having rapid eye movement sleep behavior disorder, your quality of life is much worse. If you have trouble sleeping at night, avoiding naps is something smart you can do. Now, some people have really difficult time avoiding naps. They have to nap during the day. It is recommended that you nap 20 minutes or less. Avoid naps that last more than 30 minutes. So in studies, it has been shown that if you nap 30 minutes or more, you transition from one stage of sleep to the other, and if you interrupt it at that stage, you feel worse when you wake up. If you nap less than 20 minutes, you're getting the type of sleep you need to feel refreshed when you wake up. If you can't do that, try to set up an alarm before you nap and wake up. That is helpful. Exercise. Exercise can help a lot because first, exercise at least once per day, and preferably in the morning. Try to avoid exercising late at night. When you exercise, all the neurotransmitters in your brain, the balance gets more towards the wakefulness. If you remember, we showed all the neurotransmitter and the sleep wakefulness. And if this balance goes towards the wakefulness, you'll not be able to sleep simply because you just exercise. So try to avoid exercise after 3 or 4 p.m. And try to exercise early morning. That's the best. Try to maintain a good sleep environment. So try to make sure that your bed is comfortable, the environment is comfortable, it's not too hot, it's not too cold. You don't have light in the room because, as you remember, light can trigger the suprachiasmatic nucleus that we talked about. That's the nucleus that trigger the on-off of sleep. And use earplugs to avoid noise, okay? Avoid drinking coffee. Avoid using cigarettes, especially if you're having a problem with the sleep. And avoid using electronics at least 30 minutes before you go to bed. If you're in bed now and you cannot sleep, okay, for 15 minutes or 20 minutes, don't stay in bed, because then you're fighting something that you cannot fight. Try to get out of bed, go do something relaxing, like read a book with a dim light or anything you like, listen to very quiet music for about 15-20 minutes until you feel sleepy. Then go back to bed and repeat that, okay? All this is part of something we call sleep hygiene, which is a behavior that we encourage in patients with Parkinson's disease. A lot of Parkinson's disease patients come to our clinic and say, oh, we have tried that. You really cannot try that unless you have a checklist and you check it all. Because sometimes people may say, oh, we try this, we don't use electronics, but they also drink coffee and they smoke and they use their electronics before you go to bed. So it's important for consistency with us and with your health to try to keep a checklist and try to check everything that you're doing. Now, even despite all this, patients with Parkinson's disease still experience problem. And that's when we sometimes recommend behavioral therapy with a clinical psychologist. So those clinical psychologists are trained to employ cognitive and behavioral approaches and something called biofeedback that we're going to talk about to promote sleep. Sometimes there's something called mental imagery technique that can be used and that can improve the sleep-related behavior. So what's biofeedback? Biofeedback is when they teach you how to listen to your body. It's exactly how you're hearing it. It's listening to your body. So you would feel when your muscle is contracting and try to relax it. You would feel that your heart rate or your breathing is going up and you try to relax. You try to take a deep breath and slowly exhale. So those are all exercises learned during the biofeedback. Guided imagery is different. It's when they teach you how to imagine that you're doing something. When you're in bed, for example, imagine that you're in a quiet place and try to use all your senses to engage all your senses in this experience. For example, try to imagine that you're smelling something nice and you're not hearing anything. So all those techniques can be used and are useful sometimes in patients to promote sleep. Light therapy has been known to improve sleep in patients with Parkinson's disease, and it doesn't have to be as bright as a direct sunlight. This is a type of light that is in between very dim light and sunlight, and if it's used 30 to 60 minutes per day, it trains the suprachiasmatic nucleus and the other part of your hypothalamus to get engaged in sleep at the right time. And this type of therapy is available and is useful sometimes in certain situations. And of course, medications, whether Parkinson's disease medication, simply because in some occasions you cannot sleep because you're wearing off of your medication, and we suggest that you take an extra tablet of carbidopa levodopa when you wake up or just before you go to bed to promote this state of on and try to help you to go to bed. Dopamine agonists, I'll give examples here, like pramipexole, ropinirole, rotigotine patch. All those can have vivid dreaming, can affect your dreaming. You can have vivid dreaming on those medications, or you can have sleep attacks, and your doctor usually talk to you about this before they start the medication. If that's the case, talk to your doctor because switching your medication can help you sleep better. So what can you try? Melatonin can be tried. And melatonin, it's tricky because we don't know exactly what dose help which patient. And that's why we start usually with a low dose and ask the patient to increase. Increase the dose, and as soon as they get benefit, stick with the same dose. Some patients get benefit from 3, some patients get benefit from 5, some patients get benefit from 10. In one study, they even mentioned 50, but we don't usually go up that high with melatonin. If you're depressed, this can cause insomnia, okay? And treating your depression is key to improving your sleep. We cannot give you medication that improves sleep without treating the cause. Sedatives are the last resort, but we use them sometimes when patients are resistant. So what's rapid eye movement sleep behavior disorder? Let me show you a video here that can help visualize things and explain this phenomenon.
Sleepwalking or people talking in their sleep. But there's another sleep disorder that you probably have never heard of. It's both bizarre and terrifying. Health editor Dr. Maria Simbra has more, new at 5.
David Moorhead would kick in his sleep. while he was dreaming.
Both legs, both feet, as hard as I could kick. Because most of the time I was fighting with someone, or it was anger.
This was a symptom of a sleep problem, REM sleep behavior disorder. Your body cycles through REM, or rapid eye movement sleep, every 60 to 90 minutes, with most of it occurring later in sleep. Its function isn't clear, but normally during REM, a phase associated with dreaming, your muscles are paralyzed. But for some people, something goes wrong.
REM sleep behavior disorder, patients abnormally will move and they'll act out dreams. So a common complaint people have is that they're kicking or punching or fighting.
It can be quite serious.
I have seen patients who will punch through the wall at night and end up with broken bones. I have seen patients who have hit their spouse and caused physical harm, not anything on purpose, but it's just a manifestation of the disorder.
I sat up on my knees in bed and punched the wall at the head of the bed as hard as I could in the midst of a deep dream. And I do remember that because my hand hurt. I landed right here on this tile floor, out of bed, diving for a football in a fumble in a football game.
No one knows why it happens, though in some cases it can be traced to sleep medication, antidepressants, and alcohol. There is a link with certain neurodegenerative diseases such as Parkinson's disease, though the two do not always occur together. It can also be seen with other sleep disorders. David, for example, also has sleep apnea, a problem where he stops breathing while asleep. He was also evaluated for restless leg syndrome, which occurs during non-REM sleep, just like sleepwalking and sleep talking.
Those are what we call non-REM parasomnias.
A sleep study can show a person being active during REM sleep. Luckily, the disorder responds well to treatment, such as a sedative called clonazepam, or high-dose melatonin, a sleep hormone. Also, bedroom safety is part of the treatment plan, moving the bed away from the window and moving lamps and other objects away from the bed. With medication, David is doing better.
I don't have as much movement and as much action.
I'm Dr. Maria Simbra, KDKA TV News.
So this is an example of patient who doesn't only have rapid eye movement sleep behavior disorder, which is most of, it's very rare to see a one sleep disorder isolated. You'd often see a patient with Parkinson's disease who have one or more sleep disorder, whether it's insomnia, whether it's insomnia plus rapid eye movement sleep behavior disorder, whether it's obstructive sleep apnea, insomnia, and rapid eye movement sleep behavior disorder, in addition to restless leg syndrome, which is common in patients with Parkinson's disease. So what are the two main features of rapid eye movement sleep behavior? Number one is loss of muscle paralysis, which does not happen in patients with Parkinson's disease or when you have the disorder. The muscle paralysis does not happen, and that's when you tend to punch, move, stand up, start walking, and the vivid dreaming, which is the other part. This sometimes can precede Parkinson's disease and can sometimes happen 20, 30 years prior to Parkinson's disease. Sorry about that. So how do you diagnose rapid eye movement sleep behavior? You diagnose it from history. Either the patient remembers that he dreamt and he woke up with bruises, or he woke up not on his bed. And the most critical part of this is to get a sleep study, because to diagnose rapid eye movement sleep behavior, you would need to document that the brain is undergoing this stage of rapid eye movement while the body is not paralyzed. So your sleep doctor will place leads, the EEG leads on your brain to document what part of the sleep is this, and then would place other sensors on your muscles and will test exactly if those muscles are relaxed during this stage or not, because if they are not and they're supposed to, then there is rapid eye movement sleep behavior disorder.
Can I ask a question about that? The nightmares and whatever. In our case, it's not every night. So is it still a REM disorder?
Yes.
Okay.
Yes. So it doesn't have to happen every night. It can be really infrequent. So infrequent, you can have it one night and then for 10 other nights you'll have nothing and very good sleep and then have it again. That still qualifies for diagnosis of rapid eye movement sleep behavior disorder. But as I said, a sleep study is usually recommended because you'll have to document how the brain is talking to the muscle and what stage is that. Other sleep disorder that I'm not going to dig into today can cause similar pattern and can be confused sometimes, and that's why it's important to have this sleep study to document it.
Thanks.
Anybody has other questions?
Just a question, you mentioned 4 hours or 7 hours, which should be nominal, but is that accumulative? Say I take a 2-hour nap, can I get away with a 6-hour night?
It's preferred.
I just wondered how.
So if you remember, I said to avoid naps. So if you're napping during the day, that's okay, but just try to do it for less than 20 minutes and one time, if that's possible. All right. The rest has to be overnight. So if you go to bed at 9, you wake up at 5, you're doing good. If you go 10, wake up at 6, you're doing good. If you go at 9, wake up at 2, stay awake from 2 till 5, then going back at 5, that's not good. Well, that's what we think it is. So we try to, so getting this bulk at one time is better than getting it scattered throughout the day. But very good question. So what's sleep apnea? Sleep apnea can happen in Parkinson's disease and in patients without Parkinson's disease. And it is important to recognize and treat because it's a major source of other problems. So there are two types of sleep apnea. There is an obstructive sleep apnea, and that's when you have problem in your airway and the air cannot get in, and you snore a lot overnight. Sometimes you stop breathing for a few seconds, and the oxygen in your blood goes down. Those are the features of the disease, and that's when the soft tissue in the back of your throat collapses and closes the airway. And there's another form of sleep apnea called the central sleep apnea. That's when you have a problem in the sleep or in the breathing center in your brain, in the lower part of your brain, that doesn't trigger the sleep, the breathing. This picture shows how this soft tissue that I talked about in the back of your throat would collapse and would prevent this arrow, which is the air, to flow inside your lungs. That's why the oxygen goes down and you start experiencing problems. So what? I mean, so let me talk first about the symptoms of obstructive sleep apnea. So if you're a loud snorer, if somebody is witnessing or is watching you when you're asleep and is witnessing those episodes of breathing cessation where you completely stop breathing for 5 or 7 seconds or even longer, and sometimes they get scared because this episode can last even longer. If you abruptly awaken by gasping or choking, if you get a morning headache, if you're distracted throughout the day in the morning, or if you get really irritable with high blood pressure without an obvious reason, those are all symptoms of obstructive sleep apnea. So it's important to keep an eye on this. Diagnosis goes through a sleep study. Usually a sleep doctor would order that, and they would either could be done in a facility where they would keep you for a sleep study overnight, or they would place a sensor and send you home and document that the oxygen in your blood is going low when you're having those spells. So what happens if you have obstructive sleep apnea? Well, you have Parkinson's disease, and having obstructive sleep apnea on top of it is obviously not good because you will experience high blood pressure, coronary artery disease or heart disease, strokes, depression, socially you'll not be doing good. Family life is not also good because of this. So all those can be consequences, and treating the sleep apnea can get rid of this part of the problem. So treating it comes with a CPAP or a BiPAP. The difference is the CPAP actually administered only an inspiratory phase, so it would push the air in, but the BiPAP has a bilevel where you have an inspiratory and expiratory pressure and try to simulate how your body is. Avoid alcohol, avoid sleeping pills. Weight reduction is very important. Often We diagnosed obstructive sleep apnea in patients who are obese or have a high BMI index. And the last option is surgery. Any questions about obstructive sleep apnea?
What's that EPAP?
What's what, I'm sorry?
EPAP?
EPAP is a nose, so that's, some patients have problems with the mask, to wear the mask. As you remember, David in the video was wearing a mask because he had like pre-sleep disorder, obstructive sleep apnea, rapid eye movement, and restless leg syndrome. So for his obstructive sleep apnea, he's wearing the mask. And some patients cannot tolerate this mask or the pressure from the mask, so they use a nasal pressure device. Restless leg syndrome is also a common problem. It's when you experience an unpleasant sensation in your legs resulting to move them. That's when you lay in bed and you start feeling, my legs are not okay, I'm just not comfortable and I want to stand up and start walking. And when you do that, it goes away until you go back to bed, then you start experiencing the same symptoms again. And it's frustrating because first, it wouldn't let you sleep, and second, it's just an unpleasant sensation that affects your life. So there are two types of restless leg syndrome. There's a primary and there's a secondary restless leg syndrome. In medicine, we refer usually to primary disease when we don't have any other disease causing it, or it's not a symptom of another disease. We refer to secondary when it's usually a symptom of another problem. So, as you can already imagine, primary RLS, we don't know the cause, but for secondary RLS, there are many causes. For example, kidney disease and patients on hemodialysis often have this problem. Iron deficiency is also something we checked for in patients with RLS. Medications, especially anti-nausea medication, antipsychotics, and antidepressants like fluoxetine or sertraline can trigger the restless leg syndrome. Not in all cases, but in specific patients, they can trigger the restless leg syndrome. Alcohol, nicotine, and caffeine are all problems that can trigger the restless leg syndrome, and pregnancy, in addition to neuropathy. And that's why when somebody comes in for evaluation of restless leg syndrome, the doctor check for an iron profile, check basic labs, and check a nerve conduction study, EMG, to see if he's got any neuropathy in his legs that can be responsible for his restless leg syndrome. So it's important to know that restless leg syndrome can happen in patients with Parkinson's disease too. It overlaps with it. The two don't share the same pathology, but they are treated the same. So it's not that patients with restless leg syndrome have also a problem with the substantia nigra of their brain or the dopaminergic cells there, but they are treated with dopamine agonist, and dopamine agonists oftentimes help with that restless leg syndrome. It is also important to know that not everybody who experiences those symptoms, especially in patients with Parkinson's disease, tend to have restless leg syndrome, because simply what you may be experiencing is a wearing off phenomenon. So just before you go to bed, your dopamine in the brain is going down and you start feeling the sensation of restlessness that you may misinterpret as standing up and walking as restless leg syndrome. So that's why it's important that your doctor judges on that before you make the assumption that, oh, I have those symptoms, I think I have restless leg syndrome.
Question.
Yes.
I think I'm probably suffering from the second one, but I take the extended release levodopa when I go to bed. But that only seems to work for about 5 hours. After 5 hours, I wake up, and that's when I'm experiencing the leg problem.
Right.
Should I be taking it, getting up and taking another?
So did you try taking another one and see?
I have once or twice, and it does seem to help.
Right, so it's most likely that you don't have restless. It's most likely that you're wearing off and you're experiencing symptoms of wearing
It's
off.
okay to take another one then,
Right.
if that's not part of
Right.
Okay.
So no specific tests exist for restless leg syndrome. It's all history and exam and ruling out other secondary causes of restless leg syndrome. Treatment, it really depends on if it's a primary restless leg syndrome or a secondary restless leg syndrome. If it's a secondary restless leg syndrome, treating the cause of it is obviously number one. So if you're deficient in iron, treating the iron. If you have neuropathy, treating the cause of neuropathy and trying to reverse it. In some cases it may be reversible, in some cases it's not reversible. If certain vitamins in your blood are low, usually replace them. For primary restless leg syndrome, you usually use the dopaminergic drugs that we use in Parkinson's disease. So if you have a Parkinson's disease, you're diagnosed with restless leg syndrome, you're likely on drugs that can help with restless leg syndrome. They have to be tweaked to get the best of it. Other medications that can be used are gabapentin, very common medication used for nerve pain, as well as pregabalin. Rarely we use opioids like methadone. That's in advanced cases of restless leg syndrome, but that's an option, especially true when you have augmentation problem. So patients with restless leg syndrome can be prescribed a dopaminergic medication called levodopa. You know, you're all familiar with it, and when it's administered and the symptoms are not well treated, then the dose can be increased. And when the dose is increased, the symptoms may be triggered simply by increasing the dose, and you're into a cycle now. That's called augmentation. Until you're on a very high dose with symptoms that are very resistant, happening early in the morning till the end of the day, consistently there. So that is usually, treated by decreasing the medication that is causing the problem, which is levodopa. Ironically, this is used usually to treat the restless leg syndrome, and using other medication like the methadone. So daytime sleepiness. This could be from anything. It could be because you're having insufficient sleep. It could be because you have insomnia, sleep apnea. It could be from a medication side effect. So excessive daytime sleepiness is usually assessed by using scales. This is by the way, this is the leading cause of fatalities from motor vehicle accident in the United States. So this is a serious problem. And to screen for it, we usually use either the Epworth Sleeping Scale or the Stanford Sleepiness Scale. And we use certain tests that are done by a sleep doctor usually, and they test the multiple sleep latency or the maintenance of wakefulness test. And that goes with the sleep or with wakefulness. This is an example of an Epworth Sleepiness Scale. And they ask you if you fall asleep, if you're sitting and reading, if you're watching TV, going to in a car while stop for a few minutes in traffic, then you fall asleep. This is another test for the severity called Stanford Sleepiness Scale, and that gives you a rating. Of course, it heavily relies on treating the underlying cause for your cause of sleepiness. And medications like amphetamines can sometimes be used when we don't know what's going on, and in certain sleep disorders. All right, and that's all for today. All right.
I got a question.
Okay, go ahead.
For Parkinson's or sleep apnea, hyperbaric chamber therapy, is that any?
That is an option. Did you try the mask first, or?
Oh yeah, I have sleep apnea. I've had it for 12, 20 years.
All right.
So I'm just wondering about, I've heard about hyperbaric therapy.
Right. So that is an option. Usually at that stage you would have to see a sleep doctor. A regular neurologist is unlikely to be able to help you with the obstructive sleep apnea. Did you try the nasal and the mask? You tried both? Okay. It's important to be aggressive though, and not to neglect the problem. So if it requires a hyperbaric chamber, then.
I was just wondering, have there been any studies done with that hyperbaric chamber?
I'm not sure about this. I'll have to look it up.
My daytime sleepiness seems to be caused by the carbidopa-levodopa. I take it about an hour after I take it, I'm just wiped out, and I just feel like I have a crash. Is that normal? Or is
That is sometimes a reaction that few patients have when they take the carbidopa-levodopa. How much you take?
I'm taking the 2 pills at a time, so.
And that's the immediate release.
Yeah, 2
All right.
pills during the day.
All right.
Just about an hour later, I can almost clock them at once.
And how long would you nap like when you get this, or what would happen?
Usually if I'm near a chair or something, I'm asleep.
Right.
And I do about 5 hours a night, so I've been thinking, like you said, I'm making up for my loss at night, but
Right.
apparently that's not the
Right. So sometimes the doctor consider changing the formulation where they would provide you with a more extended release so that to prevent this peak that happens an hour after after the medication may cause some side effects in few patients. It depends on how much this is affecting your quality of life and how ready you are to change formulations. All right. Other questions? Yes, go ahead.
The little device that you wear on your wrist that monitors your sleep, is that available to the public, or is it something that has to be prescribed?
I think there are forms, so now with the Apple Watch and everything, they would have something integrated in it. But for this device specifically, I think it has to be prescribed by the sleep doctor.
Okay. And would your pulmonologist refer you back
So,
to the sleep doctor?
right, so it's either, so if you're seeing a pulmonologist, he's sometimes is comfortable treating you as a sleep doctor too. Some neurologists are both board certified in neurology and sleep, so your neurologist may also be able to take care of your sleep problems, but, right.
Is there a specific name again? What did you call it?
The actigraphy. Any device that can do actigraphy.
Okay.
All right. Okay, thank you all for attending.